It makes express my pleasure, first of all, to be part of this big conference here. Several times in Egypt, but the first time to attend such a great event. I congratulate you on the big and very nice arrangements and professional way of arrangement. Just to start with something very simple, procalcitonin. What is procalcitonin? First of all, it's an amino acid of prohormone for the hormone calcitonin. Normally, it's produced in the or from the thyroid gland, unless there is something big infection in the body or as a response to an inflammation, then it will be produced from different organs on the body, and then it will exceed the normal titration of the procalcitonin. A fearful figure here talking about the prevalence and the mortality of procalcitonin. When we look at the mortality rate due to sepsis, it's even more than stroke, cancer, heart, and HIV combined. Normal titration of procalcitonin in the body usually less than 0.5. When it exceeds 0.5 as a cutoff, up to 2, that's a gray zone where we suspect the risk of sepsis. When it exceeds the 2 nanogram, then that's a serious case where we need to follow it up and put it under medication. There are other circumstances when the PCT is elevated, but still it's not due to sepsis. For example, after the first day after the major trauma, major surgical intervention, severe burns, treatment with drugs simulating the release of pro-inflammatory cytokines which will produce the procalcitonin in a higher levels in the body. For sure, when we interpret the result, we or the doctor will consider these kind of occasions. The new definition of sepsis released last year in 2016, it shows that the new definition is focusing too much on organ dysfunction or disability. Everyone involved in this field knows the Q SOFA, when it's more or equal to 2 as scores, or when the SOFA increase more than 2 points, then we need to put the patient under this area. We need to differentiate between a normal infection or a sepsis zone. And this is very critical area. We need to rule out these cases as fast as possible and as effective as possible, and usually the blood test will help people to differentiate. How to identify the sepsis and septic shock based on this criteria? Nowadays, involving this criteria, the infection indicators is added to the SOFA or SOFA score, which represent the organ dysfunction as an indicator. And then based on that, the sepsis new criteria is a suspected or documented infection and an acute increase of equal or greater than 2 SOFA points. If we need to differentiate between a normal sepsis patient or a patient develop a septic shock, then we need to consider more critical criteria like the MAB equal to or more than 65, and the lactate. The lactate is being part of the formula, if you notice here, when it exceeds 2 in millimole or 18 in milligram per deciliter, then this is a risky criteria where it will shift from normal sepsis to a septic shock. What infection causing sepsis? Based on this kind of a study, on 4,947 infected patients with severe sepsis in an ICU. After analyzing those data, it came up with the following. Most of them is due to bacterial infection and very minor on fungi, means we exclude here no viral intervention in this formula. So bacterial is our enemy. Very strong message for those of kind of patients. Every 1 hour delay in treatment of sepsis correlate to 7.6 increased risk of mortality. Then this will ring a bell that we have to do something at that stage. So waiting for blood culture or waiting for other procedure will just waste the time and put our patients under more risk. What is the story of lactate and PCT combination in this formula? In the management of sepsis, we need two things. We need lactate. This is for the hemodynamic stabilization of our patients. And we need a gold standard parameter like procalcitonin for the infection detection and control. Out of this study, we see that lactate monitoring of sepsis or septic shock patients in ED improves the outcomes. This study shows those kind of patients with serial lactate at the left side and the ones at the middle on the right side without no serial lactates. We see that this is effectively affect the number of days mortality at 28 days percentage-wise from 31 to 44%. The length of stay as well has been affected from 4.6 to 6. The ventilator-free days from 19.9 to 16. And the vasopressor-free days from 21.6 to 17.9. The conclusion of this study showing clearly that serial lactate testing of shock patients in ED is associated with reduced mortality, reduced length of stay in the ICU, and reduced the need for vasopressors. One more study is showing the usefulness of using PCT as a marker to rule out the sepsis in the ED department. It's clearly showing here at the left side the sensitivity and at the lower talking about specificity. So using PCT showing here clearly that a negative predictive value of 98.2% for bacterial patients with negative blood culture result. So this will here also improve the outcomes if you can see with and without taking into consideration the sensitivity of this parameter and the specificity as well. Still nowadays we still can see people working on CRP. The studies showing less specificity and sensitivity of CRP compared to the procalcitonin. Another strong message here when we talk about procalcitonin. And we need to manage the way we prescribe antibiotics. It is showing very clear the treatment of suspected bacterial infections in non-surgical patients in an intensive care unit could reduce antibiotic exposure as well. And then selective pressure with no apparent adverse outcomes. So the idea here is that using such parameter might give me a hint when to start the antibiotic treatment and when to quit based on special criteria. And if you ask me, is there any clear guidelines, tell me when to quit, I will say no clear guidelines till the moment. It's like best practice in the world. And I have an example to show later on. From this study showing the use of PCT-guided therapy reduced antibiotic exposure. Looking at the left side, it counts the patients on antibiotics. On 0 day, second day, day number 4, 6, 8, 10, 12, and 14, it will show at the gray color idea about number of patients as a control sample without being under PCT test, and the red one, those patients tested with PCT, where it showed fewer patients were initiated on antibiotics and the duration was shorter. And the patients initiated compared to the usual care patient group without being tested for PCT. So again, will also show me less exposure to the antibiotics based on the PCT testing compared to normal patients. Combining PCT and lactate. Patients with lactate above than 2 millimole with PCT above 0.8. This is one example of those kind of best practices in the world. They are considering 0.8, for example, here, and combining this with concentration of 2 for the lactate. This kind of patients with this criteria had an increased risk of severe outcomes. So as a summary, procalcitonin is produced from the thyroid gland under septic conditions. Then it will be produced in all organs. It's a marker of bacterial sepsis rather than any other reason. PCT correlates with severity of sepsis, and the excellent rule out of bacterial and fungal infection using PCT showing superiority compared to normal procedure without. And increasing PCT levels support a bad prognosis, while decreasing levels support a good prognosis. This enables more effective use of antibiotics, and this is something I think we need also to focus on when we talk about budgets has to be kept for running PCT tests. The only thing we need is just to maybe direct the expenses on the antibiotics to the direction of investing in PCT tests. On the other side, I can also maintain good body system, taking into consideration the resistance for those antibiotics in the long term. PCT test aids in early diagnosis and ruling out of sepsis, and the risk stratification of patients with suspected infection. It is also used as guided antibiotic management. Let's confirm this fact as well. The lactate testing aids in the diagnosis of septic shock, keeping the criteria of exceeding 2 millimoles. Lactate correlates with disease severity, thus providing prognosis and monitoring value for patients with sepsis and septic shock. Allow me to show this video.
My mother, a 20-year breast cancer survivor, she dies of a disease that we never even heard of.
Septic shock, sepsis, and she was like, how do you spell it? I said, I don't know.
Really, does it affect that many people? Then why haven't I heard of it?
My mother, Mama, she had plans of being a gospel singer.
One glorious happy day.
They found a clot in her femoral artery. She got through that surgery, but she started complaining of a lot of weakness, couldn't catch her breath. When I heard the word sepsis, I didn't understand it.
I remember that I went to bed, woke up to find the EMTs in my room. My doctor friend called the hospital and said, look, unless somebody's coding, there's no one in there as sick as this man is right now. Get a doctor in there. In the next few hours, I had one shutdown after another, all of my organs, lungs, kidneys, eventually a heart attack. My toes were blackened and gangrenous. It was very unclear as to whether I would survive.
It was Halloween. He was up crying and crying. I took his temperature, 102.3, and his color was gray. His lips, his everything was gray, and he was not responding. We got to the hospital. He got swelled up, so he was huge. And one of the doctors said, we don't know if you'll be able to take him home. I'd been waiting for him for all these months, and I've only had him 3 weeks. He's mine. I wish I would have asked more, but I felt like I was supposed to know as a mother.
I didn't understand that any infection could result in a toxic response that is known as sepsis. It started when I went to the dentist and had some dental work. Following that, I developed an infection, and then septic shock.
I can't even describe to you the horror of seeing her die of sepsis. The body swelling up twice its size, fingers turning black, having to be intubated. It looked like someone took a shotgun and shot her in the leg. That's what it looked like.
For me, this could have a very different ending, and it's why I share my survivor story.
And the nurse, her name was Annie, and she says, "Are you ready to hold him?" And I said, "Oh my God, yes." She put him in my arms, and she says, "He's gonna be okay." I thought maybe if I share my story, somebody will learn from it.
Mama's gone, but maybe somebody else can be saved.
He said his mom passed away, but maybe somebody else can be saved. Thank you so much.